Stand by. This is your 1 minute warning to air. 1 minute.
Good afternoon, ladies and gentlemen. My name is Nirav Shah, and I'm the director of the State of Maine Center for Disease Control and Prevention. I'm joined today with Commissioner Jean Lambrou, the Commissioner of Maine's Department of Health and Human Services. We're here today to provide an update on the COVID-19 situation across the state of Maine for today, Tuesday, May 26th, 2020. We begin today's update on a sad note. The Maine CDC is reporting the 79th individual with COVID-19 who has passed away. He was a man in his 80s from Cumberland County. This is a good opportunity to pause and note that on a weekend where people across the state of Maine found new and different ways to honor those who have passed away, we too honor all of the individuals who have passed away with COVID-19 across the state. Whether they died in service to their country or in service to their community, or both. We want to pause for a moment to acknowledge not only their passing, but the loss of each and every one of their friends and family members during this time of grieving. It's also an important reminder for all of us that each of these 79 individuals across the state of Maine, and now close to 100,000 people across the country who have passed away. These are more than just names on the front page of a paper or numbers on a dashboard. Each and every one of these individuals was a person, and a person who left behind them a family, friends, and a community. And we, all of us, offer our deepest condolences to those friends, families, and communities during this collective time of grieving. Overall, Maine CDC is now reporting 2,109 cases of COVID-19, representing an increase of 35 cases since yesterday. Of those 2,109 cases, 1,894 are confirmed and 215 are probable cases. Overall, 258 individuals have been hospitalized, and at present, 60 individuals across the state are currently hospitalized. Of those 60, 26 are in intensive care units and 13 are on ventilators at this time. Statewide, 1,318 individuals have recovered, an increase of 28 recoveries since yesterday. And of our cases, 489 have been among healthcare workers. A quick update on the number of medical assets or vital assets that we track every day. Overall, there remain 394 total intensive care unit beds across the state, 157 of which are available. There are 315 ventilators across the state, 238 of which are available, and there remain 439 alternative ventilators across the state. I'd like to provide next an update on 2 outbreaks that Maine CDC is particularly engaged with at this time. The first is at the Cape Memory Care Center, where there are now a total of 67 cases of COVID-19, 47 residents, and 20 staff. Sadly, there's also been 1 individual who has passed away associated with Cape Medical Care. At the Chinbro construction site, there remain 26 confirmed cases, and as we reported last week, 11 of those 26 cases are full-time Maine residents. The others are out-of-state residents. Our investigation remains underway to try to get a better sense of how the transmission of the disease occurred and what other risk factors might have been identified that can help keep other similar types of construction sites safe. I'd also like to next provide an update on some of our overall public health emergency preparedness activities. One of the areas that has been of concern to all of us with respect to equipment is the availability of swabs and viral transport media. Again, these swabs are an essential piece of what's needed in order to get someone tested for COVID-19. Maine CDC has been receiving swabs on an ongoing basis, as well as the liquid that those swabs are transported in. And as of this morning, we have shipped out approximately 14,000 of each, the swabs, as well as the vials of transport media, to healthcare providers and healthcare facilities across the state. We have approximately 13,000 swabs on hand right now, as well as about 8,600 of the Q-tip-like swabs, which can also be used, bringing our total swab inventory to about 21,000. We also have about 1,500 vials of transport media left. On an ongoing basis, we've been receiving these pieces of equipment from our colleagues at FEMA. As we receive them, we immediately are able to push them out. We ask that every single healthcare provider or healthcare facility out there who may be tuned in today to please make requests for those equipments, not from the Maine CDC laboratory, but rather through your local county emergency management agency. They can immediately route the request up to Maine's emergency management agency and right over to the public health team to try to get that filled as quickly as possible. And finally, I'd like to just provide a quick update on our continuing efforts to fit test healthcare workers across the state. Overall, 1,305 healthcare workers across the state have been fit tested by our colleagues at the National Guard, but as always, they've got more work ahead of them. There are an additional 446 individuals who remain slated for fit testing across the state. I'd like to again take a moment to thank our colleagues at the National Guard for their continuing partnership with us as we've tried to get as many healthcare workers across the state fit tested so that they can take advantage of the protective benefits of N95 masks. So with that, I'd like to turn things over to Commissioner Lambrou for a discussion on contact tracing.
Thank you. Governor Janet Mills announced today that Maine is significantly expanding contact tracing by increasing the number of skilled staff and volunteers, harnessing innovative technology, and securing social services to help people with COVID-19 maintain self-isolation. Contact tracing is the process of identifying, assessing, and protecting people who have been exposed to disease. This prevents transmission of infection to others. Taken together, testing and contact tracing enable Maine to identify, investigate, and isolate individuals with COVID-19 to prevent its spread in the absence of effective treatment or vaccines. Maine's contact tracing system has 3 parts. The first is increasing personnel. The Maine CDC currently has a contact tracing and case investigation team of approximately 30 people. It expects to more than quadruple this team as needed through the following steps. First, immediately we are enlisting the help of 50 trained volunteers who have offered their skills through Maine Responds, a system to tap into healthcare, public health, and emergency volunteers to respond to emergency situations. These volunteers will assist us for at least 2 months and will start their training on June 1. Second, we're going to begin hiring up to 125 contracted staff over time for up to 12 months to supplement Maine CDC's work. This hiring will be staggered in stages based on COVID-19 trends and data and will prioritize proficiency in multiple languages to help address the disproportionately high rates of COVID-19 among racial and ethnic minorities. And third, we're deploying SARA Alert System. The SARA Alert System has been developed to help track contacts. Specifically, it will help report daily symptoms through a web, text, emails, or calls. The tool provides real-time insight and increased capacity to support these individuals and contain the virus. It also enables hospitals and health systems to conduct contact tracing for their own employees. It does so in a way that's privacy protected and links to social services and supports, which is a third part of our strategy. Maine will be expanding its social supports to ensure that people who are in self-quarantine or self-isolation can stay alone when they are struggling with low income or housing needs or mental or substance use disorders. To address these challenges, DHHS is expanding its services through contracts through Community Action Programs, or CAPS. Once finalized, these arrangements will offer individuals in isolation or quarantine support such as delivered meals, prescriptions, and behavioral health counseling. The CAPS will subcontract with minority-run, community-based organizations to provide culturally appropriate services. We will also contract with Wabanaki Public Health for support for Native Americans and Catholic Charities, which operates the state's refugee program, to help with language translation, interpretation, and act as cultural brokers for new Mainers and other populations. Maine will also hire a point person to coordinate this work in recognition that social services are often as important as medical and public health services for people with COVID-19. The expansion of contact tracing parallels the Mills administration expansion of COVID-19 testing for the state of Maine. As we ramp up testing, we will need more people to do contact tracing. Last week, as Dr. Shaw noted, we tested as much as 1,000 tests per day, and we continue to build our capacity. So as we build that capacity to make sure that all people in Maine can have access to testing for COVID-19, we will similarly stage our expansion and supports for them through contact tracing. With that, I'll turn it back over to Dr. Shaw.
Great. Thank you very much, Commissioner. And we will now turn things over to our colleagues at the media. And today's first question goes to Brian Sullivan from WABI.
Yeah, thank you both. I have a question for both of you. I'll start with Commissioner Lambrou. Just looking over the release and what you just read, can you just give us a little timetable? If you've got 30 people ready to go and you're going to start training 50 on next Monday, or I guess a week from yesterday, and then hiring up to 125, how is that all going to work, and how long does it take to train somebody to be ready to do what is required?
Sure. And I will just start by saying we are doing this in phases because the reality is we are conducting contact tracing for 100% of people with confirmed cases of COVID-19 in the state of Maine now. Mm-hmm. So we currently have the capacity, which has been increased. We have increased Maine CDC's capacity already by 50%. But we recognize that as we continue to test at a greater rate, we will find more positive cases. As Dr. Shaw has repeatedly said, when you look, you find them. Mm-hmm. And we expect to be able to train in waves. Each week we will be able to get these people learning the system, learning the privacy protections, ensuring the information is accurate, and then ensuring that their engagement with individuals is appropriate. So it takes some work to train, but we think we can train rounds of people each week. We expect this to be phases. I don't think there's an end date for this. We will accelerate as needed, but we are staging this to parallel our tracking.
That's right. I concur, Commissioner. Brian, you had a question for me?
Yeah, Dr. Shaw, a question about your current hospitalizations or the state's current hospitalizations. Based on the numbers that I have here, and correct me if they're wrong, but 2 weeks ago today we had 34 people in the hospital. Today it's 60. That's quite the jump in a 2-week span. I guess, what does that tell you, and are you concerned by that number?
So Brian asks about the uptick in hospitalizations that has occurred correctly about over the past 2 weeks. It has been gradual and then a bit more over just the past few days. There are a few observations I would make around hospitalizations. The first is that on one hand, they're a great indicator of what might be thought of as the severity of the outbreak overall. Individuals that need to go to the hospital are among the sickest of all people with COVID-19. That being said, it remains a small fraction of the overall number of active cases of COVID-19. The second observation is that hospitalizations are a bit of a lagging indicator. Anytime in an outbreak, we're always taking a look at that snapshot, however blurry it might be, of, in this case, a bullet train. And hospitalizations are often a couple of days behind, say, case counts. The average time between someone gets exposed to COVID-19 and when they might need to be in the hospital nationwide is about 8 days. So really what the numbers today that we're seeing are a reflection of events that may have happened with transmitting the disease 8 to 10 days ago. The third factor that might be driving some of this, Brian, is an uptick in hospitalizations from Cape Memory Care. The numbers there have been fluctuating, but and we can get you the latest numbers, but given the number of individuals overall that have been affected at Cape Memory Care, it's not surprising that 8 or 10 of those have had to be transferred to the hospital. We'll get you the exact number as it stands right now. But there's a lot going on the hospitalization front. We're paying very close attention to hospitalizations. As you know, Brian, it's one of the metrics that we've set forth. And every single time we discuss what the state of the outbreak is, that number of hospitalizations is one of the ones we discuss in detail. You bet. I'm going to turn next to Isha from the BDN.
Thank you, Dr. Shah. I have 2 questions. First one is for Commissioner Lambrou. Will the expanded contact tracing program be paid for by state or federal dollars? And my second question is for you about hospitalizations again.
Sure. So today's announcement about expanding contact tracing will be paid for with 100% federal funding coming through the legislation that Congress has enacted to support contact tracing, lab capacity, and all kinds of COVID-related activity. We expect that it will cost about $7.5 million.
And
Okay,
Isha, you had
thank you.
question for me on hospitalizations?
Right. It was partially answered, but can you tell me where the uptick in hospitalizations is concentrated geographically and whether it is driven by long-term care facilities apart from the one you just mentioned?
So the uptick in Isha asks for deeper details into the nature of the uptick in hospitalizations. And the bulk of those new hospitalizations have been from hospitals in the Portland, Cumberland County area. Now, as to where the individuals are coming from, it has been a mixture. Some have been from long-term care facilities, like the one that we discussed. Others have been from community transmission cases. We're looking at the data much more carefully right now to get a better sense of where those have been coming from. But just in the past 48 hours, Isha, I will tell you that the bulk of the new hospitalizations, at least in the Portland area, have come from long-term care facilities and other assisted living facilities.
Right. Just a quick follow-up. Does this concern you in terms of restrictions lifting soon in these heavily affected areas?
So Commissioner?
Sure. I mean, I think it's fair to say that every day we look at these data, both those gating criteria that includes the syndromic data, do we see symptoms out there, the case counts and hospitalization rates, as well as our capacity, because as a reminder, until there is a treatment or a vaccine for COVID-19, our goal is to make sure that capacity is high and do our best to keep our case count low. So we are looking closely at these data. Tomorrow is our day when we'll put out the positivity rate so we can see whether this higher number of cases is because we're testing more, and we will assess those plans shortly.
Thanks, Isha.
Thank you.
We're going to turn over to Amy Brown at WERU.
Thank you, Dr. Shah. Are there any updates on the Birch Bay Retirement Village in Bar Harbor? A staff member tested positive there about a week ago and haven't heard anything since. Was that the only person testing positive?
Thus far, excuse me, thus far, that's the one case we're aware of. Our epidemiology team, I know, has been looking into that situation. As many of you may be aware, not long ago, we did change our approach to congregate settings of that nature and move toward offering more or recommending more universal testing in settings of that nature. And so right now that situation stands at where it has been. But as we learn more and as more testing is undertaken, we suspect that it will evolve.
Thank you. And in preparing for situations like this, I know there hasn't been another situation like this pandemic, but I'm sure public health professionals go through training and scenarios to look at what you would do with something like this. Are people who refuse to believe you or refuse to comply factored into the planning, and people who will not follow your recommendations or the governor's orders? And what are the thoughts about that among public health officials? Do you just hope that they get on board, or how is that best case scenario? How would it be handled, and how do you feel like it's being handled currently?
So Amy, I want to just clarify, for the folks that you're referring to, are you thinking about or thinking of folks who are reluctant to remain in isolation? Who specifically are you looking at?
The whole range of behaviors. Anyone who's in denial about the virus, people who believe it's a hoax, people who are just not engaging in safe behavior. I'm sure that's kind of factored in thinking about a pandemic kind of situation, that there will be some elements within the population that continue to engage in risky behavior and who don't believe you. So what is the way that should be dealt with, and do you feel like it's being done now?
So Amy asks about, as we're thinking about and preparing for large outbreaks of this nature, let alone a pandemic like this one, how do we think about individuals who may not be fully on board with public health recommendations? And Amy, what I'll say is actually two things. The first is that what we see in this pandemic and in most pandemics, according to the US CDC, is that compliance with recommendations from public health departments is quite good. When the health department calls and says, you may have been identified as someone who might have been in close contact with a confirmed case, usually what we find is folks want to talk to us so that they can learn about what they need to do to keep themselves and their families safe. And that's what we've observed here. The other observation I'll make, Amy, is what's really been striking about COVID-19 is not so much the people who have not wished to comply or get on board, but rather the speed with which everyone else has agreed to do so. I mean, if you really think about a lot of what public health does, is that we work with folks to try to give them the tools to help them adjust their behaviors in a way that might be more healthful. Obesity, smoking, vaping. And those processes can take years. But with COVID-19, in a matter of a couple of months, a couple of weeks, what we saw was that folks across the country were willing to stay inside to slow the spread, to now wear face coverings. It's really been remarkable, not so much that people haven't gotten on board, but really the speed with which they have agreed to work with public health officials. That, to me, is what's been quite remarkable. But, Amy, of course, in any situation, not everyone is going to want to be on board. That's just a fact. And, what I ask my team to do as we call folks who are skeptical or reluctant, I think the number one question we can all ask other people who you may know that aren't really on board with what's going on is not so much what they believe, but why. What would it take for somebody to come around to the idea that this is a serious concern? And I think when we start asking people why they believe what they believe, rather than just telling them what they should believe, I think that's when the real conversation starts. Commissioner?
No, I would just add that we do have backstops in the state of Maine for people who should be in self-isolation who are not, but we have not had to use it to date. We have had good compliance with all of our recommendations from Maine CDC, in part because of this approach.
I'm going to turn next to Eric Russell at the Press Herald.
Yeah, hi. Good afternoon, both of you. Thank you for taking the time. A quick follow-up to that line of questioning. How do you sort of measure compliance? And, how are you sort of getting a handle on how many people are following these recommendations? I think of that in light of this past weekend when we likely saw a lot of visitors coming in from out of state and people who might have, not followed the quarantine. They might have just came in here and did what they want and left. I mean, how are we really monitoring that effectively? And then I have another question after that.
Sure. So our approach to enforcement during this public health crisis is to remind people that is what it is. It is a public health crisis. The violations that are occurring are violations that put people in imminent risk, at danger. So with that in mind, we, number one, start with prevention. We do our best to provide information on what often is complicated guidance. Not everybody intuitively knows how to set up an establishment or exactly how to engage with people in settings where it's hard to socially distance. So prevention is number one with education. Number two is warnings. We really do believe that sometimes just giving people information, both what you could be doing, how you could be doing it, but also that there are consequences for not doing it, is our second strategy, and we've been doing that all along with different establishments and individuals. And then our last phase is, as needed, we will enforce it through licensure suspensions, through potential cease and desist orders. There are tools that we have at the state level during this crisis to enforce it. We have had very, very rare circumstances where we need to go to that third level, but we're prepared to do that, including with regard to quarantine. We know that a lot of people are looking at the pictures of the northbound part of the turnpike this weekend and wondering, have we seen a huge number of people coming into Maine? Are they self-quarantining? The reality is traffic was down 50% this weekend, this Memorial Day weekend, over previous Memorial Day weekend. That said, we still do have the 14-day quarantine requirement in effect. We do expect people coming into the state or leaving the state and coming back to self-quarantine, not just for themselves, but for their friends, their neighbors, and their families.
And for Dr. Shah, I wonder if you can address sort of what you've seen in terms of behaviors from people this past weekend, whether it's people getting out and about more in places where restaurants have opened and other places have opened, especially in light of the fact that the rest of the state is going to open up beginning next week, likely.
So Eric asks about just observationally, what have we seen, what have we heard? And just in my goings out over the weekend, whether it was to run to the grocery store, what we saw, what my family and I saw, was remarkable compliance with face coverings, prohibitions on bringing in reusable bags. I really think it speaks a lot to the fact that folks want to do what's best for their community, but it underscores what Commissioner Lambrou said. I think our job is to make sure that those expectations are clear. When the expectations are clear, easy to abide, at least what my family and I observed is that they were followed.
Thank you.
You bet. I'm going to turn next to Michael Fern from the Maine Edge.
Hi, Dr. Shaw. Both my questions are for you. First, when store capacities were first determined, it was based on social distancing and not wearing masks. Since masks are now mandatory, can store capacities be revised upward as it gets hotter?
So Michael's first question is whether, given that face coverings are now more of a staple than when they were initially introduced, when the store restrictions were introduced, can restrictions be upped so that more people can be in stores? And Michael, I think that's a challenge. Although face coverings are yet another layer of the approach that we're taking on top of limiting density within stores, we do have to be careful. Face coverings are just one piece. Another piece of that is that space. I think both of them in concert with one another. The one-way aisles, the limited density, coupled with the face coverings, are really three parts of that, really the three legs of the stool that will maximize, or in this case, minimize the amount of transmission that occurs. I think it's something that we'll be taking a look at, but for right now, our view, or my view at least, is that the more approaches that we can put simultaneously on the table to limit transmission, the better off we'll be.
Sure, thank you for that. And my second question is about data. Can the table of cases by age be expanded to include deaths by age, or do you have that data?
So we're making a lot of effort right now, literally just this week, to try to expand the amount of data that's portrayed on our website. So that's one of the items on the agenda for our data and analytics team. We've brought on additional individuals as well to assist with that. I'm not sure where that is in the which ones are going to be rolled out first, which versus a bit later. But certainly those are the more concrete, granular types of epidemiological data that we intend to be releasing soon.
All right, thank you.
You bet. I'm going to turn over to TJ Tremble from ABC 7.
Good afternoon, Dr. Shaw, Commissioner. Commissioner, I'm wondering if you have mentioned it already, the 14-day quarantine. You mentioned it earlier this afternoon. I'm wondering if in your work groups, if there's any movement toward loosening that 14-day self-quarantine restriction.
Sure. So the 14-day quarantine restriction is not just in Maine. It's used by most states in the nation. It has been recommended by public health professionals because there's frankly not that many good alternatives. If we all had good alternatives like a vaccine, like a treatment that makes COVID-19 like a common cold, we would be more than happy to relax that 14-day quarantine. Mm-hmm. All that said, we continue to listen and engage with all people, be it the experts, looking at other states, talking to different industries that may have ideas on are there safe alternatives to 14-day quarantines. We won't give up. We'll continue to look and see if there is one because we respect the fact that it is challenging to enforce as well as challenging to live under. So we continue to look at all available options. We have none today, but when we find one, we'll let you know, as well as the citizens and people of Maine.
Excuse me.
No, please.
What are some of the options being considered?
We just continue to look at what different states are doing. There may be testing involved in it. There may be screenings involved in it. There may be other types of precautions that people could take if they're coming from out of state. But again, at this moment, we don't have an alternative.
Thank you.
Thanks, TJ. Did you have a question for me, TJ? Nope. Okay, we're going to turn next to Duke Don Kerrigan.
Yeah. Good to do it. Good afternoon, Dr. Shaw, Commissioner. I have a question for the Commissioner first and then one for Dr. Shaw. Commissioner, the steps you announced today on contact tracing what's new there? I mean, Dr. Shaw has been talking about this really for a month or so, and it seems like now we're just finally getting underway with it. Is that the case? Are we kind of slow to roll this out? If so, why?
So I would argue what's new about today's announcement on what's new about contact tracing today is our ability to scale. That ability to scale comes from, number one, technology. We have launched this Sarah Alert system, which is a platform that allows us to use technology to more effectively touch people, to get their symptoms, to really ensure that they're doing the right thing, to kick them over, hopefully, to social services so they'll be able to more effectively self-isolate. So the technology is new. We have to date used it for about a week, and I think we have 345 people who are in the system, which is exciting. The second part that's new is enlisting and engaging these two new workforces that can go to scale. We hope we don't need to have 205 contact tracers or people in the system, which is what we announced today as our maximum capacity. And as a reminder, that puts us on a per capita basis at a higher amount of contact tracing than the state of Massachusetts, which has a much bigger epidemic than we have here in Maine. So that's new, that we have these two different ways to scale up through our volunteers and through these contract staff to really get to where we need to be if we need to be there. We hope we never need to use all those people, but that's new and different. And third, the social supports part of it is really important. It is not easy to self-isolate, no matter who you are, and it's particularly challenging if you are a person who's homeless or a person with mental health issues that you have chronic illness, so you need medications. That poses special challenges to people in self-isolation. We're announcing through these contracts with our community action agencies and other partners supports so we can make sure that they have the food, the support, the mental health counseling, that they can effectively self-isolate, which will further improve our ability to prevent the spread of COVID-19.
Don, if I could chime in on top of that, for everyone who's watching, even though we're making the announcement today about some of the newer steps we're taking, I do want to note that contact tracing is an essential part of all public health outbreak investigations, not just for COVID-19, but for a number of other infectious diseases that we track. In addition, from the very first probable case of COVID-19, way back when that was, Maine CDC has been contact tracing each and every single positive case. So that process has been underway for decades before COVID-19 and since the very first case of COVID-19 in Maine. As we scale up testing, we're now scaling up our contact tracing. But it's always been happening, but now we're going to be scaling it up.
Okay, thank you. And I've got a question for you, Dr. Shah, to the perennial issue of town-by-town reporting. More and more people seem to be calling for the state to join the rest of the country and report numbers of cases by either community or zip code. It appears most other New England states are doing it with no problem with privacy. You mentioned last week that Maine might be moving towards that. Can you give us an update on that? And why do we still resist when everyone else seems to have solved the problem?
Sure. So Don asks about our work to release data on a more granular level. Don, as I mentioned a moment ago, we're working on expanding the offerings that we have on our website with respect to COVID-19 data and hoping to have some announcements and some updates there soon. One of them will hopefully be releasing COVID-19 data at a more granular level sub-county. What that ultimate level turns out to be, we're still working on. The particular challenge in Maine, Don, to your question, is the fact that we have a high number of zip codes and municipalities with very few people in them. And so we've got to come up with a system, a procedure, an algorithm that protects the privacy in those sparsely populated parts of the state. If we've got a township with 50 people in it, and we announce that there's one case, well, a lot of folks are going to pretty much know, geez, so-and-so had a cold about a week and a half ago. I wonder if that one case is that person. That's one thing that differentiates Maine from smaller, more tightly packed states, even in the Northeast, let alone across the country. So it's not so much that we have been against the idea. What we've also needed to do is get to a certain number of aggregate cases so that our overall case count would be large enough so that we could start making those delineations. Honestly, it's not been a question of whether to do it. It's been a question of when we could do it, given the sufficiently high number of cases that we would need to have in order to protect people's privacy. We've pretty much reached that number of cases for our population on a per capita basis. We've pretty much gotten at the point in our outbreak where other states were when they've started releasing that data. We believe that we can now move toward doing so while balancing and maintain the balance between keeping people's privacy as well as providing people with more data on what's going on. So I just want to say it's never been a no. It's always been a when and under what conditions.
May I briefly follow up?
Yes, go ahead.
Thank you. So New Hampshire, which has roughly twice the number of cases we do, they've already implemented this. They have towns just as small or even smaller than some of ours. Have they been able to figure something out that we haven't about privacy, or is it, in your opinion, simply the matter that they have more numbers?
So I think it's that they have twice as many cases in fact, more than twice as many cases as we have. We are now at the point, and so Don asks about how we stack up against New Hampshire. They have twice as many cases as we have in Maine with roughly the same population. They also have overall a higher density of population. They've got about the same number of individuals as we do and a much smaller state. What all that means is that even though there are some small towns there, there are many, many more small, low-density populated places across the state of Maine than there are even in New Hampshire. So we've got to create a system that respects that and make sure we don't inadvertently release someone's identity And so given that we now have a higher threshold of cases than we did, say, a month ago, we have more ability to do that because there are just more cases across the state.
Thank you.
You bet, Don. I'm going to turn next to Steve Missler over at Maine Public.
Thank you, Dr. Shaw. And I'm not sure who wants to answer this question. I just had a clarification on the contact tracing effort, specifically which metrics you guys will be using to deploy the additional contact tracers, and also a logistical question along the same line, which is if you're waiting for a specific time to hit, a certain threshold in the data, is that perhaps too late to get people trained and on board and everything else and deployed into the field, or are you training them in the background in anticipation of hitting whatever metric that it is that you're using to use more contact tracers?
Sure. I will just say, not jokingly, I hope we're too late. I hope we don't need the capacity that we're bringing on, because that would mean that we are able to maintain the current level of contact tracing that we have in the state of Maine without adding these two new tranches of people, these trained volunteers and the staff contract workers. But as you've heard us say all along, our job is to be ready, and that's what we're trying to do. So we are, as you know, we're doing more testing. Our testing capacity basically doubled last week at the state lab. We know new testing capacity is coming online in private labs, so we do expect that we're going to see a climb in the number of tests in the state of Maine, tests per capita, which is why we're doing this now. We don't think we're too late. We have an ability, though, if things rise rapidly, to speed this up. Our systems are in place, and we're ready to go.
Yeah, I guess if you could just clarify again, what data might you use to deploy more contact tracers, and or is there a scenario in which that might happen? Can you just sort of help paint me a picture? I'm just trying to envision how this would work. And again, are you training people in the background in anticipation of using them, or is that or are you going to train them after you've hit that whatever this threshold is?
Sure, and I will say I think it's as simple as case counts. We are watching you. We contact trace every new confirmed case. So that really is the metric that we're tracking as we try to figure out our capacity. We do have, and I should say this, different levels. I think we have 7 different levels of job descriptions within our contact tracing scheme, from the true disease detectives, our epidemiologists who do the hardcore work, to investigators, to monitors, to people who enroll and track the data. So it is a team of people who do this. And we are training now because we think it's important to not wait and then train. We're training and then waiting.
Steve, I wanted to pick up on something that Commissioner Lambrou just noted. We, there are, even though we talk about contact tracing as if it is one thing with one type of person, it's in fact a process that has many twists and turns in it, depending on the nature of the outbreak or the nature of the individual. If what we see are a high number of single cases in the community, that requires one type of contact tracer, someone to enroll somebody in Sarah Alert and check in with them from time to time. If the nature of the outbreak in Maine evolves such that it's a lot more complicated facility level outbreaks, that may mean we'll need to accelerate our hiring of epidemiologists, who are the more in the weeds disease detectives. So it depends not just on the raw number of cases, but on the location of those cases and what we learn about each of those. So in this situation, we would have approximately a week of lead time in order to get somebody trained up and ready to go. And that's about the lead time that we would need based on what we'd be seeing in the data on any given day.
And I'll just add one point. We are also trying to expand the diversity of our contact tracers. We recognize that we have racial disparities in our COVID-19 outbreak in Maine, as in many other states. And we know it's important to have people who have the cultural background and intelligence to engage with people to make sure that they understand the disease, understand what they're supposed to do, and support their families or communities as we do contact tracing.
Thanks, Steve. Before I turn to the next question, Don, I'd like to just go back to the question that you raised about rolling out data. One other important piece of data that we look at as we're thinking about privacy versus, or in addition to providing more data, comparing ourselves to New Hampshire, as you noted, just the number of towns in the two states differs quite dramatically. New Hampshire's got about 220 towns, while Maine, just statewide, has over 480. So just the number of people per town is quite different in Maine versus New Hampshire. Each of these calculations goes into how we think about making sure we could protect privacy, but that's another important data point I wanted to note for you, Don. And I'm going to turn next to Dan Newman over at the Maine Beacon.
Hi, thanks for taking my call. This question could be for either Commissioner Lambrou or Dr. Shaw, I guess. One thing that we've been hearing from immigrant community leaders in Lewiston is that there's a lack of safe housing options for those who contract the virus to safely quarantine away from their families, who are often living in large groups in denser housing. Is that something the CDC or the state is working to address?
Sure. So Dan asks about supportive and safe isolation locations for individuals, particularly those in the Lewiston area, among any population, but specifically amongst New Mainers. And Dan, we're certainly aware of that concern. We've had a number of discussions with representatives from New Mainer populations, and that concern has been voiced time and time again. As a result of that, as a direct result of those discussions, not just in Lewiston, but in other parts of the state as well, we've worked with area hotels to strike contracts with them so that individuals who don't feel that they can isolate without potentially exposing other members of their family can be offered a place to isolate safely, as well as then receive the necessary social, clinical, and psychological supports they might need through that long and difficult period. So we're aware of that concern. We've worked to address it. Commissioner, I'll turn it over to you.
No, I was just going to have the same thing and say we have been lucky to have colleagues in the Maine State Housing Authority who have been our partners in this effort. And again, this is not the first community, but we've learned from the other communities, and we have established safe housing for people in the Lewiston area who need to self-isolate outside of their homes.
Mm-hmm. Thanks, Dan. I'm going to turn to Megan from WMTW.
Thank you for taking my question. My first question is actually for Commissioner Lambrou, and it was, I believe, sort of similar to Steve's question. But when you answered Commissioner Lambrou, you were talking about the diversity of contact tracers in terms of the volunteers, and you said trained volunteers. Are these volunteers that have a background in training, or just volunteers that you will be training? Meaning, what is some of the backgrounds of people you'd be looking for, I guess?
Sure. So we are fortunate in the state of Maine that we have, I want to say, over 4,000 people who have responded in this pandemic to volunteer through this EM response system. They're mostly, again, clinicians, healthcare providers, EMS workers, people with public health backgrounds. So with that kind of database to pull from, we are looking for people who have this direct experience, because that will enable us to more quickly and effectively deploy them into the field. We are, again, overlaying on top of that a look for people with geographic diversity, with racial and ethnic diversity, with different types of skills, so we can complement our Maine CDC team. And the same holds true for our contract workers. We are going to more aggressively look again to see, can we find people with some experience to preferentially hire them so they can hit the ground running.
Thank you. And Dr. Shaw, if I could, I would like, could you maybe just update us on the situation at 100 State Street? The CDC has said there's 23 case investigations. Can you clarify what a case investigation means? Does that mean that those are confirmed cases, positive cases, or are they presumptive or suspected cases? And maybe if you could go into if there are any further measures being taken to protect or distance the residents at 100 State Street.
Sure. So Megan asks about 100 State Street. And Megan, as of right now, we've identified through the lab testing that was undertaken last week 23 individuals who reside at 100 State Street who have tested positive for COVID-19. What we mean by investigation is really synonymous with contact tracing. Contact tracing, or when we talk about investigating situations, the core of that, the crux of that, is contact tracing. So our teams are now, our contact tracers, are now touching base with the individuals who tested positive to try to get a sense of who else they may have interacted with within their building and outside their building, what other exposures they might have had. Were they all, for example, at the same setting together 6 or 5 days before they tested positive? What else can we learn about the nature of their lives that might help us, A, reach out to others who might have been exposed, and B, help us learn something about COVID-19 that could help other communities similarly stay safe. That process is ongoing. That's really the core of what contact tracers do. It's a good exemplification of why contact tracing is important. Given where we are right now, that process with a large building and a large number of individuals, it will take a number of days for more data to be generated, for more interviews to be conducted, before we're really able fully to piece together what's going on there. In the meantime, we're working with the management and other individuals to make sure that there are safeguards put into place by the building management and ownership to try to limit interactions and reduce any further spread. I'm going to turn next to Brad Rogers over at WGME for today's last question.
Thanks, Dr. Shaw. I have one for each of you. York Hospital is going to be opening up a COVID-19 testing site at the high school on June 1st. Do you know how many of those mobile testing sites we have now in the state, and how important do you feel that is to getting more testing out there?
Can we do it?
Go ahead.
Sure. So on mobile testing, I think you have a lot of different terminology that gets kind of mixed up in it. Mobile testing actually means mobile. That there is a van that we have been working with that is going to be able to do mobile testing in areas where we have agriculture workers, for example. We have drive-through testing, and drive-through testing comes in 2 forms at least. One is what's called swab and send. That is where you get the sample taken at the site, but then it gets sent to a lab, sometimes in-state, sometimes out-of-state, and you get your results the next day or 2 days or multiple days later. There's also drive-through point-of-care testing, which uses this ID Now test, which, as Dr. Shaw has talked about, is pretty good at detecting a positive, not so good at detecting a negative test. But that is one type of drive-through testing that's out there that may be not ideal for public health purposes, but may be valuable for different purposes. And then there's the traditional, you can get tested at a clinic and in a hospital. Some recent mapping efforts found that we have about 38 testing sites outside of your doctor's office in the state of Maine. We want to expand that. As we announced last week, we have a $52.7 million grant from the federal government for expansion, and we'd like to see more of those swab and send sites geographically in the state to make sure we get to our rural residents, make sure that we get to areas where we have more dense population. So we have about that many sites, but we want more.
Agreed. Brad, I don't have anything to add on top of that. Did you have a question for me as well?
Well, I did. Actually, I had another one, I think, for Commissioner Lambrew, but you can answer too if you want. On the SARA system, exactly how is that going to work? Is that where I believe you call and text them and to find out? Is the purpose of that to make sure they're quarantining themselves for 14 days?
So,
what's the purpose of all that?
This is going to be one that we'll both answer because I think we both have learned about the system. It's a technology platform where you're basically able to enter in information on individuals who are getting into the system. It allows people to get through text, email, phone calls, reminders, because oftentimes part of self-isolation is getting that information to give them tips, symptoms, extra help is needed, they need social supports. I mean, it's a system that will be using technology to improve our ability to support people in self-isolation.
So, Sarah Overt, Brad, is, if anyone's really interested in it, there are a number of really nice short YouTube videos that walk through what it does and how it works. I want to emphasize a few things about it. The first is that it's completely free. It was free for the state of Maine to use. The second is that it happens to have been designed in part by a former health department director, our counterpart from the state of Vermont many years ago. And so it was designed with the needs of health departments in mind. And what it does for us is that it's that critical link between individuals who may be isolated or quarantined and the Maine CDC. It provides a number of different ways for individuals who have been diagnosed or who have been identified as contacts to report to us how they're doing and for us to check on them. If someone is comfortable using text messaging, that works for Sarah Alert. If they're much more comfortable talking to somebody on a phone, Sarah Alert can do that too. If they're a lot easier typing something in on the web and filling out a questionnaire, Sarah Alert can accommodate that as well. So it really does meet people where they are and allow us to interact with them in every single way. But among its many benefits, in addition to the ones I just mentioned, is that it also can be adapted for the needs of our state, specifically for populations for whom English may not be their first language. Sarah Alert can very easily use modules that can translate all of these questions into whatever language is more comfortable for somebody. So in that respect, it's not only efficient in terms of keeping data up to date and allowing us to check in on folks and see how they're doing, it also means that we can do so not only where they are, but in a manner that they are the most comfortable contacting and interacting with. So we're excited to be rolling it out.
And I will just add that language capacity is in the works. Maine is actually helping to develop some of these languages, not just for Maine, but for the rest of the nation.
For the country.
And it is privacy protected. I think that it's just always important to remember that the information that is in the system is safe and secure. Part of that training that we're making people go through is to make sure that they respect people's privacy, they understand the laws and the rules that protect it, and we intend to, again, make sure that we're doing this effectively but safely for the people of Maine.
Great. Well, we thank everyone for taking some time out of their afternoon. Commissioner Lambrew and I are delighted to be able to provide updates on where things stand with COVID-19 across the state, across the country. Thank you also for taking some time to join us this afternoon. We look forward to chatting soon. Have a great afternoon.